Thank you very much. I'd like to thank again everyone for having me here. I'd like to, a special thanks to Costa for giving me a topic that he knows much more about than I do, but we'll go through it. And I think it's important when we talk about some of these techniques that many of us in this room will never use them, but we should be aware of them because maybe in certain situations they should be assessed by someone who may have competence, experience in these situations, and the patient should be looked after by them. Okay, so TAVI, we know in today's TAVR is very predictable. And I say that most of the time. We take our time, initially screening patients with echo to ensure that they do have severe AS. And then with CT imaging, annulus sizing, vascular access, other imponderables, we look at the whole annulus area, the sinus, the sinotubular junction, the LVOT, looking for calcium, looking for size. And this is something that we never did in the early days, but very important. And because of this predictability, 90% of TAVI is generally done skin to skin within 30 to 60 minutes. And it allows us to be very efficient and get our patients home early. Valve-in-valve is a special situation, which can be sometimes the quickest procedures, but also sometimes the most unpredictable and longest ones. And we need special care. And I do worry when everyone thinks we're going to be able to do valve-in-valve in the future in every single patient, because that's not going to be the case. Especially, my preference is to send aortic stenosis, if they go to surgery, to a surgeon who is experienced in aortic valve surgery, and they do a root enlargement. That actually may make it harder to do a valve-in-valve in the future, although the initial outcome will be much better. This is when it gets real, and we've all had this situation, I think almost all of us, where we have left main occlusion. It can happen with any valve in any situation, native valve, valve-in-valve, and this is the one that's pretty scary. And again, we have a better understanding now to prevent this and also to fix it if it does happen. And again, we know that once it does happen, the mortality rate is quite high. And again, in the VIVID registry with a valve-in-valve, you can see it's approximately 50% when you have this. And we've learned to help protect this. You can see again in the literature, there's a lot of examples of this. And just by looking at these, and we get accustomed to looking at angiography, we can see that there's not much room in there. So again, these are worrisome things. And again, when we look at the sinus, we see how much room is actually going to be in there. We see a valve, and then to sort of estimate what a valve-in-valve will look like and get an idea, are we going to encroach on that left main or the RCA? We always talk about the left main, but the RCA is very important too, as many surgeons know when they come off pump with RCAs that are problematic. So predicting this is not always easy, and we do have a set of guidelines with impeccable CT imaging and looking at virtual sizing, trying to account for flaring of certain valves, trying to account for positioning. We get a sense of which ones are going to be high risk. And there's a gradation. It's not yes or no. Often it's no problem, no protection. Others are, it may be a problem, no protection, and then we go down the line, protection, just in case. And the ones that we're very, very concerned about, I think we need to discuss as a heart team, what is the best way to do that? Is the best way to proceed with protection, the best way to consider surgery, or maybe something else? And we'll talk about that something else in a second. Risk factors for coronary obstruction, valve-in-valve, and we've seen them all. There's the anatomic risk factors. There's the bioprosthetic valve factors, because every valve is different, whether it's a TAVI valve or a surgically placed valve. And also transcatheter valve factors. And again, that's one reason why we need to know our equipment. What we are putting in, we need to know both the strength and the limitations. And again, everything doesn't happen in isolation, they interact. So, is protection always works? Most of us in this room have done that. Most of us in this room have had to put in a stent in the left main because we were not happy, either a partial occlusion or a full occlusion. And most of the times we can stay out of trouble and it's not an issue. However, And there's different ways to do this. Most of the times I don't put a stent in. I'll put if I need to protect, I'll put a stiff wire with a non-compliant balloon, unless I'm very, very concerned and there's no option for surgery or other options. But we have to be careful when we put stents in, because trying to pull them out, we may strip the stent off. And even if we get a good result, does that result last a long time? How do we treat that patient? Anticoagulation, dual antiplatelet therapy, long, short. A lot of these patients are frail. They don't tolerate anticoagulation well. So these are things that we need to think about. And you can see we can have a patent stent, but following them afterwards, there is issues often, and they can restenose, and treating these are very difficult. So, basilica procedure, something that was brought up to potentially treat patients at high risk of left main occlusion, but patients maybe that are not surgical candidates. I think if patients are very good surgical candidates, we have to still think of that. And I'll show this here so everyone gets a sense of what that is. And again, we saw some of those images early on, where we go through the valve, or the leaflet, and cauterize it essentially, splaying it open. And it may not look like it does anything initially, but with that opening and placing in the other valve, it provides flow through the cage, and again, protects that left main. And it can be done bilaterally, it can be done into the RCA, it can be done just the RCA, but it is an option. And this is what it looks like, and pretty impressive when you actually see it that this should work. Here's an example by Danny Dwyer, who presented here last year. And you can see in a trifecta valve going through convienza or other type of stiff wire. And still protecting the left main, because there's still issues sometimes. And basically snaring it and pulling it out and putting the valve in place, and everything should work out fine. But again, still protecting it. I think it takes a brave person still not to protect it. And happy with the flow, and the patient did well. I think in de novo valves, if there's a concern about actually closing off the left main, and the patient is a good surgical candidate, then we should think of surgery in these patients. And yesterday's talk, using potentially sutureless or other type of valve, maybe just traditional valve surgery, but if it's a higher risk patient, maybe sutureless, minimal technique. We can go in and potentially do it that way, where they can actually excise the leaflets and put in this valve. So this is a chance where, again, the heart team and individualizing therapy works. How about the mitral valve? Well, we know, again, through the talks earlier today, that mitral valve intervention is a bit more difficult in my mind and more complex than aortic valve interventions. And I do not do, other than balloon valvuloplasty, I don't do mitral clip. But putting in new valves does cause, you're replacing one disease with another. And the one that we're worried about is LVOT obstruction, and that's an Achilles heel. So, an example of a complex procedure, and everything looks good. Everyone pats themselves on the back. Here's the hemodynamics prior to this, and here's the hemodynamics after. And really, this is you can see here, even though it's atrial fib, a Brockenbauer type sign, where you have obstruction in the left ventricular outflow tract, and it's problematic. And there are modeling that can be done to assess whether or not the valve you put in, will it affect this LVOT. And again, it's important not just looking in diastole, but looking in systole. And when you actually look at mapping, you can see that the new LVOT is very small, and that's not a successful result. So some people who were very brave and very smart decided to try different approaches to this. And again, knowing that that leaflet, the anterior leaflet, is the cause of much of the problems. And it does have a hokum-like physiologic effect, and can occlude that LVOT. So the LAMPOON procedure was thought out, and a few people have done it and tried it and have been successful with it. But it is complex, it does take time. And I'll show you an animation of this as well. Again, getting the sense of this. And I'm hoping with the new mitral valve implants that are going to be coming down the line, that they'll have some type of solution to this. Because I think if we take putting in a percutaneous valve, and then having to do this every time, and then turning this into a 5-6 hour procedure, well, a surgeon can do a mini mitral much quicker, much more efficiently. So again, these are the early days of this, and I do believe that things will get smoother and not require these interventions. But for the time being, this is an intervention that you can see keeps the cages open and keeps the flow out. An LVOT obstruction, again, mostly by that anterior leaflet, but also the septum. Maybe that can be ablated afterwards, an alcohol ablation, or we can do surgery with a transatrial resection, which was shown earlier today. So again, Lampoon does address many of these issues, and there is in the at NIH an ID protocol underway, and hopefully this will be used. And again, it's going to be used only by a few people initially, because it is complex, it does take time, and not everyone will have the patience for this, that's for sure. So my take-home message from both of these techniques: the recent TAVR studies, again, are pushing us to a higher percentage of patients undergoing therapy, especially for valve-in-valve. We don't want a resternotomy. Lower risk patients, in my mind, have more to lose, because these are the patients that actually, when you look at partner 3 and the low risk Medtronic studies, surgery does well. So we have to make sure that we are impeccable in how we do these patients to actually do better for them. Pre-planning is important, and Basilica may help in certain patients, whether it's in native valve or in valve-in-valve. And there are promising, looking at the mitral valve, promising techniques coming down the pipeline here, which may require, techniques to prevent this neo-LVOT obstruction from occurring, and Lampoon may help here. But we need studies, and we need more improvements on the technique to make them easier and more useful to more patients. And this is a study, I wanted to show this. This is a patient that we had done almost 5 years ago. And the reason I'm showing this, Costa, I showed this to the group here. This was the 29-year-old woman who was pregnant, and we did a valve-in-valve, no CT beforehand, just sort of taking a guess on what to do. Sorry about that. And we did a valve-in-valve on her because she wanted to maintain her pregnancy. And knowing what I know now, I don't know if I would have been so cavalier as to do the procedure, and we ended up doing it. She did give birth, and it's almost 4 years ago. The child's doing well, and the patient's gradients are still very acceptable. We do expect her to need a valve replacement, maybe a Ross procedure in the future, but sometimes a little knowledge is a good thing when it works out, but not always. So I just want to show that just as follow-up for the attendees here. Thank you very much.
Thank you very much. Excellent, Dr. Velianou.